All right, let's go ahead and get started. Happy Friday, everyone. Welcome to another installment of Geography Colloquium coming your way from the University of Colorado Boulder. Today, we are privileged to be hosting Dr. Danielle Ely, health statistician from the Division of Vital Statistics at the National Center for Health Statistics of the CDC. Today's talk is entitled Birth and Infant Deaths in the United States. Dr. Danielle Ely received her MA in Sociology from Wichita State University and her PhD in Rural Sociology and Demography from the Penn State University. Her dissertation examined reproductive healthcare utilization over a woman's life course across the rural and urban continuum. She currently works in the reproductive statistics branch within the Division of Vital Statistics, a division in the National Center for Health Statistics in the Center for Disease Control and Prevention. She's the data manager for the linked birth and infant rate file and works preparing files for public and restricted use, writing CDC publications, and working with a variety of stakeholders to ensure national data and births infant deaths are as accurate as possible. I know a lot of folks here at CU use these data products, so we are very privileged to be hosting this talk. Without further ado, I'll pass the baton to Dr. Ely. The floor is yours.
Thank you so much. I am so happy to be here today and to present to all of you. My talk today is going to be over births and infant deaths in the United States, which is using data from the National Vital Statistics System. So what do we do? Well, I work in the Division of Vital Statistics, and we contract with all 57 vital statistics jurisdictions in the US to collect all the data on births, fetal deaths, and all mortality in the United States. We are mandated by federal law to disseminate national statistics on vital events, and we do so by providing public use microdata files as well as restricted use microdata files, putting out reports and having data access tools such as CDC Wonder. The reproductive statistics branch, which is the branch that I'm in within vital statistics, has two different teams. The first team is the birth team, which is what I am a part of, and we do a final review and dissemination of vital stats on fetal deaths and infant death data, as well as birth data. And we include, which includes national microdata files, our annual and special reports, and special data requests. There's a second team that is within the reproductive statistics branch, and that is the National Survey of Family Growth. You may or may not have heard of this. So they design and field the National Survey of Family Growth, and they also put out data files and reports on that topic. So what do I do specifically? I manage the National Linked Birth and Infant Death file. So I am doing the final review of the data file after it's been put together by a separate DVS branch that directly receives data from the 57 jurisdictions. I review and approve the many microdata files that are created for public and special use. I field data requests on the linked file, and I also author publications. So some of you might be wondering, although some of you might not, what is the linked birth and infant death file? So the linked birth and infant death file is a data set where infant deaths are linked with their corresponding birth certificates for analysis. We do this because the birth certificate offers details that aren't available in the death certificate. And some of this can include maternal characteristics, such as race, which is more accurately reported in the birth certificate since the individual is providing that information rather than a coroner. Other details that are available include pregnancy risk factors, which can include things like hypertension or eclampsia. And we also have items that would be related to the infant, so infant characteristics and conditions, which might include things like birth weight or congenital anomalies. So the linked infant mortality data literally links the birth and death certificate data together for infant deaths. And we have two different file types. We have what is the period file, which is more timely. And what that has is 2 birth years and 1 death year. So for example, an infant could have been born in 2016 or 2017, but they would have died in 2017. We also have the cohort file, which is a file that contains 1 birth year and 2 death years, which just means that we're following the same infants over the span of their first year of life to see if they die. So if the birth year was 2016, the infant may have died in 2016 or 2017. However, we were able to do something new to make the cohort data more timely. So starting with the 2016 cohort data year, which would be 2016 births and whether the infant died in 2016 or 2017, we've made a single file combined with the period file so that users can create their own cohort files from the period files, which is something that has been wanted for a long time, but we have just gotten around to. So infant death is defined as a live birth that is followed by death before 365 days of age, so before 1 year. There are 2 ways that we further classify infant deaths beyond just being less than 1 year of age, and that includes first neonatal, which are those deaths that occur within 28 days of age. And this can be broken down into 2 further categories of early and late, where the first is dying before 1 week of age, and the other dying between 1 week of age and 28 days, so 4 weeks. The second way that we categorize infant deaths is post-neonatal infant deaths, which are infant deaths that happen between 28 days and 364 days of age. So the linked birth and infant death data releases happen with annual data releases, and they are available on our Vital Statistics online data portal. I've included a link on this slide. And in that data portal, you can find all of the available years of microdata files and the user guides that are available. Now that all states are reporting on the 2003 standards for the birth certificate, we've restarted releasing an annual standard report that is looking at the linked period file infant mortality. Additionally, you can find our information on the CDC wide-ranging online data for epidemiological research, or what we call WONDER. And in WONDER, the linked data files are available from 1995 to 2008. And we have an expanded data set, which includes essentially all of the items in our data file that's available for 2017 and 2018. So CDC WONDER provides researchers not only with the data, but also with the reference materials and reports and guidelines on topics. And the WONDER allows users to use a fill-in-the-blank system where they can choose different characteristics. For example, if you wanted to look at infant deaths that were only happening in one state, you could select one state. And then you could say, I want to see the infant mortality rate for, let's say, Colorado. And after you saw that, well, I only want to see infant deaths that happen to male infants. So there are a variety of ways that you can use WONDER to quickly gather information about infant mortality or births or fetal deaths or general mortality. However, one disadvantage to WONDER is that you cannot take the data from WONDER and do any kind of detailed analyses. So some examples of the reports that we've done using the linked file data include topics such as the differences between rural and urban areas and mortality rates for the leading causes of infant death, looking at just the general infant mortality by age of death, the effects of changes in the maternal age distribution and maternal age-specific infant mortality rates on infant mortality trends, and looking at maternal characteristics and infant outcomes in different regions of the US compared with the US as a whole. So some examples based on those or of reports that we put out include our annual report that includes infant mortality trends, looking at US specific and region specific reports, and some rural urban research. And that is what I'm going to be talking about today to you, using my past research that's been published to give examples of ways that you can use our files to look at different geographic components. To start, this is just the polling the infant mortality trends from 1995 to 2017, or excuse me, 2018. And so you can see over this time, there's been a slight decline overall in the infant mortality rate from 7.57 down to 5.67 in 2018. Some of the United States and region specific research that we have done has looked at either the United States as a whole by broken down by state. We've also done research that has included looking at rural and urban areas. We've used our data files to look at Appalachia and Delta versus the United States. And one thing that I have to point out now, since we are talking about geography and geographic components, is that although the overall infant mortality trends can be found in our public use data files or using CDC Wonder, you would not be able to do a detailed analysis without having access to the restricted geography files. The process for this is not too complicated. Essentially, it's filling out some paperwork that's available on the website and then sending it in to us. And then now that our branch has taken over looking at the infant mortality and the birth requests, they go through relatively quickly. So this is something you might think about if you're interested in doing any research that's related to births or infant deaths, is getting our geography restricted use files. Unfortunately, while you can actually find state rates on Wonder, it wouldn't allow you to do the analyses. So for the first example of a more geography related research would be the map here that has the 2018 infant mortality rates by state. As you can see, this range from less than 4.0 to 8 to 8.9 infant deaths per 1,000 live births. And the actual range was 3.5 infant deaths in New Hampshire, all the way to 8.41 infant deaths in Mississippi. And the overall infant mortality rate in the US was 5.67. So one question you may have right now is, why am I talking about 2018? Well, because we have data that has to wait until, wait a full year for an infant to die or wait until the next year of data, we don't yet have the 2019 data. We are in the process of getting the rest of the data fixed from the states and verifying that everything is correct before we can create our files to make them available. So the 2018 data, we are generally about 2 years behind the actual year on our data year. Following up on these, previous report that we put out looked at the differences in infant mortality rates by state by the three major race and Hispanic origin groups, being non-Hispanic white, Hispanic, and non-Hispanic Black, from 2013 to 2015 combined years. The reason that we looked at it like this was we wanted to show the ways that the race and Hispanic origin groups differed in infant mortality rates across the states. So in the first map, you can see that the infant mortality rates for non-Hispanic white, for infants of non-Hispanic white women, they actually range from 2.52 in Washington, D.C., all to 7.04 infant deaths per 1,000 live births in Arkansas. So in general, this is relatively good, especially as you move over. For infants of Hispanic women, the range was from 4.23 infant deaths in Florida all the way, Yes, and all the way to 7.28 infant deaths in Michigan. And finally, on the far right, for infants of non-Hispanic Black women, you can see that there is hardly any overlap. And in fact, you would, as you look closely, there is no light green in this map compared with the other two maps. So for non-Hispanic infants of non-Hispanic Black women, the infant mortality rate ranged from 8.27 in Massachusetts to 14.28 in Wisconsin. So the entire purpose of this report was to show these drastic disparities between non-Hispanic white and non-Hispanic Black, or Hispanic and non-Hispanic Black in the United States. Another report that we did looked at infant mortality in the Delta, Appalachia, and the rest of the United States for 2016 and 2017. And this actually used a combination of both birth data and infant mortality data. But the example that I pulled here was to show the infant mortality rates by mortality status or marital status in the Delta, Appalachia, and the rest of the US. So in this example, the infant mortality rate was highest in the Delta for infants of married and unmarried women. But you can see that the highest infant mortality rates by marital status occurred for infants born to mothers who were unmarried with no paternity acknowledged, while rates were lowest for all regions for infants that were born to married women. The following slides show results from research focusing on maternal residence at birth as rural urban and maternal characteristics and birth outcomes. So the examples I'm going to give you focus on fertility rates and birth rates, the mother's mean age at first birth, general infant mortality and by race and Hispanic origin, and leading causes of infant death. For each of these projects, we use the following definitions that are available as the NCHS population definitions, which include 3 categories that we used were large urban, which is an MSA of 1 million or more, small or medium urban, so MSA population of less than 250,000 or of 250,000 to less than 1 million. And we also used the rural categorization, which is micropolitan urban population of 10,000 to less than 50,000, and also non-core areas. So here is a graphic showing how you could further identify these. And throughout the rest of the presentation, I'm going to use terms such as urban and metro interchangeably. However, there are some contentions on whether you should do that. And I am open to debate if someone wants to discuss that. However, in this presentation, this is how I will be discussing each of the results. So to start looking at births by urbanization level, at the fertility rates and age-specific birth rates, as well as mother's mean age at first birth. The first project and the first section of results was looking at trends in fertility and mother's mean age at first birth among rural and metropolitan counties in the United States from 2007 to 2017. So what we did was we used the birth files and we pulled data from each of those years and calculated total fertility rates for rural, small or medium urban, and large urban counties. So from 2007 to 2017, total fertility rates declined across urban and rural areas. The total fertility rates declined 12% in rural areas, 16% in smaller medium urban areas, and 18% in large urban counties. The difference in the total fertility rate between rural and smaller medium urban counties actually increased from 2007 to 2017, from 5% difference in 2007 to 10% difference in 2017. Additionally, the differences in rural counties also increased over time compared with large urban counties. Specifically, it was a even wider gap than compared with the smaller medium urban counties. It was 5% in 2007 and 14% in 2017. Next in this project, we looked at the mean or average age at first birth over this same time frame. sorry. So over the same time frame, there was an increase in the mean age at first birth by urbanization level for all three categories. Mean age at first birth increased 1.3 years for rural areas, 1.5 years for small and medium urban counties, and 1.8 years in large urban counties. And one of the reasons that we like to track the mean age at first birth is that in general, women who have children and have their first birth at an older age generally have better outcomes to a certain point than when we were having a lot of births by teenagers or even young adults, such as 18 or 19-year-old women or women in their 20s. So the difference in mean age at first birth, the gap in this widened over time. In 2007, there was a 1.1 year difference between rural and small and medium urban counties. And by 2017, there was a 1.3 year difference. There was also a greater difference between rural and large urban counties between 2007 and 2017. This gap increased by 0.5 years from 2.7 year difference in 2007 to 3.2 year difference in 2017. In the next project, we were looking at age-specific birth rates by urbanization level for women aged 15 to 44. And we used the 2017 birth file, and we only looked at rural versus urban in total rather than looking at two different. Hello?
So we lost you for just a second and we lost your screen. If you can share it again.
Yes, sorry about that.
No problem. I'm glad you're back on.
Okay.
You can see your screen now. So
Okay. And where did you lose me about?
I think we followed all the way. It was just a momentary.
Okay, not a problem. Not a problem. Here we go.
Right.
Okay, start this one again. So in 2017, women in rural counties under age 30 had higher birth rates than women in urban counties. And women in rural counties age 30 and over had lower birth rates than their urban peers. In 2017, the highest birth rates in rural counties were to women aged 25 to 29, who had 126.4 births per 1,000 women, whereas in urban counties, the highest birth rates were to women aged 30 to 34, where the birth rate was 101.7 births per 1,000 women. So overall, when I was talking about the birth data by urbanization level, so rural counties compared with urban counties have had higher total fertility rates and lower mean age lower mean age at first birth, and they also had higher birth weight rates for women under 30, but lower birth rates for women 30 and older. When looking at infant mortality by urbanization level, I'll be discussing infant mortality rates in general, infant mortality rates by race and Hispanic origin group, as well as the mortality rates for the leading causes of infant death. For the overall infant mortality rates, we put out a release that looked at the 2007 and 2015 period-linked birth and infant death file data. So for all three areas, being the large urban, small and medium urban, and rural counties, rates declined from 2007 to 2015. However, there were differences in the rate of decline. So infant mortality rates were 5% higher than the smaller medium urban counties in 2007, but 7% higher in 2015. And infant mortality rates in rural counties were 17% higher in 2007 than large urban counties, but that gap increased to 25% higher in 2015. If we break this down and look at the infant mortality rates for metro and non-metro counties by race and Hispanic origin, For this, we use the 2017 period linked file to describe these rates. In metropolitan counties, excuse me, in metropolitan counties, infant mortality rates were lowest for infants of non-Hispanic white mothers, where the rate was 4.50 infant deaths per 1,000 live births, which was followed by rates for infants of Hispanic mothers, and the rates were highest for infants of non-Hispanic Black mothers. In non-metro counties, the main difference was that infants of Hispanic mothers had the lowest infant mortality rates, followed by non-Hispanic white mothers, and then again, the rates for non-Hispanic infants of non-Hispanic Black women was the highest. What is interesting about this is that when we are looking by race and these three race and Hispanic origin groups, there is only one difference between metro and non-metro counties within a group that's significant, which was for non-Hispanic white women. The rates for non-Hispanic Black women and for Hispanic women or infants of these women weren't statistically different in 2017. Another project that I was a part of was looking at the 5 leading causes of infant death for 2013 to 2015 data combined, using the period linked birth and infant death file. So the 5 leading causes of death are listed here. They're congenital malformations, low birth weight, sudden infant death syndrome or SIDS, maternal complications, and unintentional injuries. So among these 5 leading causes of death, you can see there's a bit of variation across the rural and urban counties. In terms of places where rural counties, infants in rural counties are doing worse, so infants in rural counties had 12% higher rates than small and medium urban counties for congenital malformations. They had 35% higher rates for SIDS, and they had 18% higher rates for unintentional injuries. The gap becomes, oh, excuse me. And compared with small and medium urban counties, the rural areas had 9% lower infant mortality rates from low birth weight and 21% lower rates from maternal complications. In contrast, we can see that these differences are even larger when comparing rural with the large urban counties. Specifically, rural has 35% higher rates than large urban counties for congenital malformations. Rates were nearly 100 or more than 100% higher for SIDS and 82% higher for unintentional injuries. Rural counties also had lower infant mortality rates from low birth weight and maternal complications compared to the large urban counties, the same as it was for the small or medium urban counties. So overall, infant mortality by urbanization level. So rural counties compared with urban counties have higher overall infant mortality rates, and these rates are consistently higher for the race and Hispanic origin groups presented. Additionally, rural counties have higher infant mortality rates for 3 of 5 leading causes of death, which were congenital malformations, SIDS, and unintentional injuries. And finally, rural counties were advantaged in the way that they had lower infant mortality rates for 2 of the 5 leading causes of death, which were low birth weight and maternal complications. So an overall summary of what I've shown you here today using our files that has mostly focused on rurality or urbanicity, however you want to look at it, is that fertility and birth rates are higher in rural counties than urban. The mean age at first birth is lower in rural counties than urban counties. Infant mortality rates were highest in rural counties and lowest in large urban counties. And rural counties had the higher infant mortality from congenital malformations, SIDS, and unintentional injuries, while having lower infant mortality rates from maternal complications and low birth weight. And with that, that is the end of the presentation based on the previously published publications from us, and I'm happy to take any questions.
Well, thank you very much, Danielle. This was amazing. I'm sure the audience is clapping at home. I have folks on YouTube. Feel free to ask your questions on the chat box to the right of the video. You should be signed in with your personal Gmail account. The Google's way of calling this is a YouTube channel. It's not much beyond your Gmail account and accepting the terms to leave YouTube comments. There won't be a channel on its own. No video of you will be shared. I don't know why Google insists on calling in the channel before you can leave comments. And if you get signed out or you lose the page, we'll be here for a little bit so that you can come back and ask your questions. In the meanwhile, if you don't mind, Daniel, I actually have a few questions. The first one is probably the most difficult one because it's just logistics. Going back to the geographic specific files, how fine resolution are these files and how detailed can we go? Because the ones that you show, obviously there was an overlap between metropolitan areas and non-metro areas, as well as the urban size. If folks reach out and ask, request data access, will it be at a county level, at the census tract level? How? I know there's not lots of data, but still.
So we do have county level data, and it is we have all counties, obviously, where there has been an incidence of birth or infant death or fetal death, depending on which of the reproductive statistics branch file you want. And so it is not available yet, and I cannot definitively say when it will be done. However, I know that they are looking at geocoding addresses and trying to find a way to provide more detail specific geography level information for researchers. But that's a project that has been in the works since I started working with my team, which was about three and a half years ago. And I know they're getting closer, but I know it has been quite an undertaking because it requires a lot of more information from the states in some cases than what they were already providing. Oh, I can't hear you.
That's a good starting point. Thank you for for folks here at Geography and IBS if they want to use these files. As I was looking at your maps, I was just putting things in my head together as we are having these regional alliances for response to COVID. I could actually see them in your maps initially, with Iowa aside, and I believe another Midwestern state. Oh, it was Montana, actually. It wasn't Midwestern, but you could see the Western Pack clearly in there, plus Colorado, and the Northeastern Pack being separately standing out. It's amazing to me, and I don't know much about this, whereas it's just the health outcomes of these regional alliances that now have formed are more similar together, or if there is policy, long-term policy that makes the outcome look more or less similar. Before I continue on my rant to ask a question, let me ask the questions from the audience. Fernando is asking, does accessing the files at the finest resolution level require a similar process to acquiring other NCHS restricted geocoded files? And what about using RDC? Is it a similar review process?
So because we actually provide the microdata files, they don't contain enough or specific identify or directly identifiable PII. And so the files are, the way I understand it, they're uploaded to a FileZilla, WebZilla, something like that, where researchers would download them directly for what we have currently. So because we're not releasing geocoded files, we don't have those available yet. It would not be through the RDC. If you requested a special file that was well, with the infant mortality file, you wouldn't be able to, but there are other files where you would need to use the RDC. But in general, our data you're going to be able to get and um, analyze on a university computer.
Okay, and because there's a 20-second delay, I will wait if Fernando has follow-up questions. But Guofen Kala, another colleague here, is asking whether the microdata is just exactly what you just mentioned. I think, again, there's a 20-second or 30-second delay, or is it on the individual level, like the way census data is collected and then aggregated?
They are individual level records. So it's
Okay.
each line contains a single birth or infant death information on a single line
Okay.
in the flat files.
Great. And I mean, my follow-up with that was one of my questions. You mentioned in the beginning of your talk that it's linked to a series of maternal information. Does that include, we saw age, for instance, and race, I assume. I don't know if that's maternal, but
It is, yes.
health
Well,
indicate.
there is also paternal race and
Great.
Hispanic origin that you can look at. There
Great.
are all there are a wide variety of demographic and health characteristics that are included. There are also some that we would love to have that we don't currently have, which would include things like income. It would be fantastic to have that, but it is a fight to get new items, which because it requires a lot of resources from the states. It does.
Right.
But we do have items like if the mother received a WIC while she was pregnant, so supplement for food. We have marital status data, and we have educational attainment in terms of demographic health characteristics. Did the mother smoke during her pregnancy? 3 months before pregnancy through the end of the third trimester? How much did she smoke? We asked, how many cigarettes she smoked per day on average. Different items like that are available in the files.
Yeah. Again, I just a little follow-up on that, and then Colleen has a question. Colleen, if you don't mind, just a little clarification in your question about the disparities. Is it between state or within state disparities? I assume you mean within each state, which states have the most inequality within the boundaries. But my follow-up for that would be health indicators of maternal health indicators. Again, sorry if I'm not using the correct terminology here. But whether information on maternal health indicators are in the file too, just as a general level.
So we do have some health indicators, or what we would consider to be health indicators, such as if they had diabetes or hypertension before pregnancy, or if they were gestational related. I'm trying to think of some. We do have BMI, so a body mass index, if people are interested in those measures. Let me think. Is there anything specifically you're wondering about, or just kind of general?
No, I think I just wanted to have general information because, again, I think there is more, going back to your first few slides than your analysis, which is going to be really helpful. I think that's a good starting point, knowing that those indicators do exist. And then let me ask a question from the audience. Colleen Reed, actually another colleague of mine, health geographer here at CU Boulder Geography, is asking whether you've spent any time exploring the reasons for state level differences. For instance, a map of which states have the largest disparity.
Okay, so
and if I may, sorry, just
no,
got a
go ahead.
follow-up question there. Instead of a map that with infant mortality rates by race as separate maps, it would be nice to see, for instance, which states have the widest differences by race for infant mortality within the states. And I think it actually occurred to me too, because when you were showing, Delta versus Appalachia and the rest of the US, and at the same time looking at the racial differences, obviously the Delta region, that is probably a lot informed by racial differences in those states. But anyhow.
Okay, yes.
Yeah, yeah, I'll copy and paste the question here just in case you want to see the actual question.
Okay, yeah. So one of I don't want to call it a complication because it is not a complication, but one of the realities of where I work, NCHS, is that we are a federal statistical agency. And if you're outside of the government, many people will not necessarily know what this means. But what it means is that I have to make sure that anything that I put out would not be taken as partisan. Everything I have to do can only be based on the data. And generally, they like us to limit it to our data specifically, though not exclusively. So we haven't spent a lot of time looking at state level differences necessarily. And part of that is because we only have so many items in the birth certificate that we can use to examine that. But we have looked at the differences, like the gap between Black and white infant mortality. We haven't done that in the last few years, but it has been done in terms of as how much higher it is. So whether it's in general, the Black infant mortality rate is about twice as high as that of whites and Hispanics, and more than twice as high in many cases for the overall non-Hispanic Asian infants. But unfortunately, I don't have too much of that I could show quickly. But we have looked at some of those things historically.
Yeah, and I'm sure our colleagues can follow up, and even these pointers are very helpful. A follow-up question by Professor Reed is whether you've looked at variables that derive the infant mortality rates by state, or really any other spatial unit there too, that, you know, the things that may be deriving the predictors.
So we have not by state. We have looked at the US overall we've done some decomposition analysis that I've been a part of to look at maternal race and maternal age over time. And we have found that, and trying to remember now what we have found, in cases where like the Appalachian Delta, we did this for trends over time. And in many cases, the changing age population of mothers, because it has gotten older over time. As I showed in rural and urban, I mean, that's just the general trend across the entire US. And that has influenced infant mortality because the oldest and the youngest mothers are the ones who have higher infant mortality rates. Generally, women in their 30s have the lowest infant mortality. Late 20s and into early 30s have the lowest infant mortality rates. And if I'm not answering anyone's question, please feel free to follow up again and say, hey, I would like some more information.
No, I think that really explained a lot. I'm going to check the chat box again. This is our first year doing this digitally over YouTube, so learning a little as we go. I will wait a little to see if there are more questions from the audience. And yeah, for me, it was fascinating to me. I would be happy to follow up on you on an individual basis. I'm looking at these regional packs and the way the U.S. Different states have banded up and responded to COVID-19, at least on paper. I don't know how much at the local policy level states coordinate, let's say, local shutdowns or testing activities. But it was interesting to me that the health outcomes on the overall infant mortality rate, that the map that you showed, I could clearly see those packs stand out. Let me thank you again for agreeing to be our speaker. This was a fascinating talk. And I want to thank you for staying within the time limit. That's really always appreciated.
Yes.
And allowing for a good discussion. I don't see questions from the audience. I'm sure you may have follow-ups. The talk is currently on YouTube, so there might be follow-up questions on that too from our students in other time zones. Otherwise, I want to wish everyone a good weekend and thank Dr. Ely for this great talk again. Have a good weekend.